And without further ado, I want to present our speakers, Daniel Clarke-Pearson, MD, and Lyn Filip, RN, BSN, OCN, for Gynecologic Cancers, a Team Approach to Women's Healthcare. And just to give you a little advance warning, our first poll everywhere question is always kind of a softball. This one is, which of the following is a form of gynecologic cancer? A, bone marrow, B, brain, C, cervix, D, lungs. Everything's anonymous. Take your best guess. That'll pop up in just a minute. And while we are waiting, before we get there, I want to say that Dr. Clarke-Pearson completed a residency in obstetrics and gynecology, Roy T. Parker, MD Chair, and a fellow in gynecologic oncology, William T. Kreisman, MD Director at Duke University in Durham, North Carolina, right down the road. He joined the Duke faculty as an assistant professor in the Division of Gynecologic Oncology in 1981. And between 1985 and 87, he was the Director of Gynecology and Gynecologic Oncology at the University of Illinois in Chicago. He returned to Duke University Medical Center in 1987 as a tenured professor and director of the Division of Gynecologic Oncology. He was named the James Ingram Professor of Gynecologic Oncology in 1993, and throughout his Duke tenure, he was the Director of Fellowship in Gynecologic Oncology. And then later in 2005 Dr. Clarke-Pearson accepted the role of chair in the Department of Obstetrics and Gynecology at the University of North Carolina, Chapel Hill, a role he filled until stepping down to rejoin the Gynecologic Oncology faculty in 2019. Dr. Clarke-Pearson, what's one thing we should know about you outside of that professional bio there?
Well, aside from getting both vaccines for COVID, and we'll talk about other vaccinations later, spent a lot of time in my mountain house out here in Ashe County, which is the most northwestern county in North Carolina.
Great. That sounds beautiful. And we also have Lyn Filip, RN, BSN, OCN, and a clinical assistant professor and nurse clinician in the Division of Gynecologic Oncology. She directs patient care for patients and families and enjoys facilitating a team approach to comprehensive patient care. She also likes her role as an educator of nurses, residents, and fellows. Lyn Filip also has a certified pet therapy basset hound named Herbie, and they work at the UNC and Ronald McDonald House. Lyn, welcome. And again, what's something you'd like to tell us about you outside of that? Or maybe to elaborate.
I talk about Herbie a little bit.
Please do.
He's making a little presentation or presentation, as he says it. But one of my real joys has been working with Herbie as a therapy dog in a variety of different areas, especially with pediatric patients who are about his size, so they really enjoy it. But interestingly enough, like many jobs, poor Herbie was laid off during COVID because of the exposure from one patient to the other. So right now, all of our good therapy dogs are taking a little rest, but he's still up to his old shenanigans here. So we need to get him back out with patients, but it's something that we both love to do, and he very much wanted to be able to say hello this morning.
Well, we are delighted to have you, and delighted to have Dr. Clarke-Pearson, and also delighted to have Herbie. So thank you all for being here. Let's take a look at that question. Which one of the following is a form of gynecologic cancer? They've had a little bit of time to answer that, and it seems like we've got 100% identifying cervix. How are they doing?
That's perfect. Yeah, 100%. We don't even need to give this lecture.
Yeah, they've got it. They've got it. But just in case, we'll stick with the lecture. So and I'm glad. So without further ado, gynecologic oncology, team approach to patient care, and I'll let you take it away.
Well, great. Thanks, Tim. This is Dan Clarke-Pearson again, and I think the emphasis of team approach is important. Lyn and I have worked together as a team, along with, and you'll see the whole host of other people that make up our team, but Lyn and I have worked together for about a little over 20 years, and
we've had a great, 1,000 years.
Well, it seemed like it, but anyway, the team approach is important. I think it's useful for the audience to know that GYN oncologists not only take care of patients with cancer, but also do complex pelvic surgery. But more importantly, we take care of the whole cancer patient. So we do surgery, we manage the chemotherapy along with our team. We work closely with radiation oncologists. So we provide the sort of the comprehensive approach to taking care of women that have these specific cancers. Lynn, do you want to say anything more on this slide?
Let's just move right along. That would be
Okay,
great.
next slide then. So our learning objectives are we want to help you understand gynecologic cancers as much as we can in an hour. And important to talk about risk factors, not only for yourselves, but also members of your family and community. And identify the opportunities for screening. Some cancers we can screen for and others we can't. So it's important to understand both, as well as the signs and symptoms of some of those cancers for early detection. And then consider your personal risk, and there is a tool for that we'll talk about. And then finally, understanding sort of the general overall treatments for the three cancers that we're going to talk about: cancer of the uterus or endometrium, ovarian cancer, and cervix cancer. We can go to the next slide.
So, and then we also want to take opportunity as you all, we need to go back a little bit. Can we go back a slide, please? For teachable moments. And what teachable moments are, and we hope to find many there for you today, are seizing the opportunity by making the time and effort to impart knowledge to our patients, or even to you all, but just taking that opportunity and emphasizing what's so important to them so the message is sent. And that goal is to increase awareness, to provide education, and in our case, it to save lives. So in a Gynecologic Oncology Cancer Foundation poll, they found with, you can just keep rolling them, 800 women that they polled. Just keep, yeah. And nearly half of the women were not aware of any risk factor for developing a gynecological cancer. So half of the women is a nearly half is pretty substantial number. 19% could not name any test for female reproductive cancers. Yet 54% believe that they're at a personal risk for developing a gynecologic cancer. That may be the other half, but that's a pretty good number. And 58%, which is really the important number, are not aware of any factors that can lower their personal risk. So we have a team approach to gynecological cancers, as Dr. Clarke-Pearson and Dr. Clarke-Pearson said. We've worked together for a long time, and that really enhances our patient care. So we have the doctors who are called gynecologic oncologists. In our model, these are doctors that provide surgery as well as chemotherapy if needed. Other modalities are radiation therapy, but that's referred to another. Down the list is a radiation oncologist. We have nurse clinicians, advanced practice providers, genetics counselors, because there are genetic links in some cancers, pharmacists, social services, and palliative care specialists.
So I hope everybody paid attention in the 7th grade biology or health class, because this is the anatomy that we're going to talk about today, and it's female anatomy in the pelvis. And I'll just walk through those organs. Of course, in the middle of this slide is the uterus. We're going to talk about uterine cancer. And then on the side of the uterus are ovaries and tubes. We'll talk about fallopian tube and ovarian cancer. And then finally down at the lower end of the uterus is the cervix, and we'll talk about cervix cancer. So these are the key female organs and the three most common cancers are what we're going to talk about today. Next. The frequency of developing these cancers in the United States, you can see on this slide, and we won't spend too much time. Uterine cancer obviously is the most common. Cervix cancer, though, accounts for nearly 14,000 cases in the United States. And I hope by the end of this lecture, you'll understand that we shouldn't even have that cancer around anymore if we had been doing a good job of doing pap smear screening and if women have been getting pap smears. And we'll go on to talk about HPV vaccine to prevent cervix cancer. So I hope in the next decade or so, we can get rid of cervix cancer in the United States, but it is still an issue. And then ovarian cancer. Other cancers, the vulva, the skin on the outside of the female genital tract, you can see there, and some other rarer cancers. But we want to talk about the top three. So there's probably some key terminology that we need to get down. So talking about origin, so the origin, where did that cancer start? Did it start in the ovary? Did it start in the uterus? And then has it spread, which is what we call staging. So we want to determine the spread of the cancer, especially when we start, before we start planning treatment. So that's called staging. If the cancer is confined just to that one organ, just in the uterus, we call that stage 1. And we go on from there. As it starts to spread, we add stage 2, 3, and 4. The grade of the tumor is, or cancer, is what the pathologist sees under the microscope. So those are the key elements to talk about as we go through this lecture.
So what is screening? It's important to define what we're talking about as we go through this lecture. But screening is a strategy used to detect a disease in individuals without any signs or symptoms. Somebody walking down the street normally feeling 100%. Screening tests are performed on those without any clinical indication of disease. So it's a patient person who we're doing a test that we have no indication that they have any signs of that. The intention of screening is to identify a disease in a community early, thus enabling earlier intervention and management in the hope to reduce the mortality, death rates, and suffering from a disease. Although screening may lead to an earlier diagnosis, not all screening tests have been shown to benefit the person being screened. And what are the downfalls of screening are sometimes overdiagnosis, misdiagnosis, and creating a false sense of security are the hazards of inappropriate screening. So screening in gynecologic oncology, and you guys toned in right on the cervix, and the pap smear is 90% effective. With the development of the pap smear, we made huge steps in identifying cervical cancer. But it only identifies cervical cancer, not endometrial or ovarian. Sometimes a pap smear can be a bit effective in endometrial, but generally it's just showing some cells that gives us a little bit warning. And in ovarian cancer, it's not a tool at all. So if you go in and have a pap smear, you're not screening for everything. Okay, next slide.
So we'll get on to this, and this is another illustration of the female pelvis from a side view. So we're going to talk about uterus, cervix, and ovarian cancer. Next slide. So endometrial cancer is cancer from the lining of the uterus, and it is the most common cancer that we take care of, so we'll spend a little time on that. We could just go on through this slide. About 65,000 cases in the United States. And lifetime risk is about 1 in 40 women will develop uterine cancer. Most will be cured, fortunately. And it is a disease that in general occurs in women that are a little older, past menopause, about average age of 60. A little bit more common in white women, but African-American women seem to have a worse outcome. Part of that's genetics, and part of that may be access to care and other issues that are important for us to sort out. Most can be caught early, and if they're caught early, 90% of those women are going to be long-term survivors, which is gratifying for me as a therapy provider. But the prognosis depends, though, on the stage of the cancer, how far spread is the cancer.
What is a risk factor? And I just want to mention one thing. When we talk about endometrial cancer or uterine cancer, that's the same. So those terminologies are the same. So they're not two different cancers. A risk factor. So a risk factor for anything is something that raises your chance of getting a disease. Risk factor of smoking, for lung cancer is the most common one. What are some in endometrial cancer risk factors? Obesity greater than 50 pounds. So somebody who has a lot of extra weight on them and is a postmenopausal woman, which we see this a lot in North Carolina, they're at increased risk. If they've undergone menopause after age 52, it increases the risk. lack of children, or not really lack of children, but not having their own children, or a small number of children, but especially those that are what we call nulliparous, or no biological children, is a risk factor. Hypertension is a risk factor. Diabetes is another risk factor. So if we look just there at these top ones there, you can keep rolling, but the diabetes, hypertension, postmenopausal, obesity, those can all be wrapped in sometime, and then all of a sudden we're looking at a woman with 4 or 5 risk factors. Estrogen replacement without progesterone, a history of pelvic radiation therapy for another disease, women who do not have normal ovulation, and diet and exercise is lack of a good diet and lack of good exercise. And there's been much more research showing that for many cancers, that diet and exercise is playing a substantial role in cancer and recurring cancer. So we look at these women and they all look like great people that we would see, but you can see some that would look like they are reducing their risk factors and some that aren't. And the middle picture shows a woman who's overweight. She's very happy, but she looks older. These younger women are exercising. A young woman who's normal weight, but it just tells you that, and the bottom woman is diabetic. So some have increased risk factors just from their pictures.
So the symptoms of uterine cancer, and the reason we can usually detect it early is because there are some symptoms. As Lynn said earlier, we don't have a screening test for endometrial cancer or uterine cancer, but bleeding or spotting is especially in menopausal women, is the thing that should set off some concern and require evaluation. So it's abnormal spotting, abnormal bleeding, abnormal spotting, abnormal bleeding. We can't ignore that. That's the telltale sign. Not everybody with bleeding is going to have cancer, of course, but we need to evaluate that patient. We don't have a screening test. Pap smears sometimes will pick up abnormal cells, but we can't rely on that as our screening test. I think we have a poll to do, right, John or Tim?
We do. So this is our first poll questions since our warm-up there. So which are risk factors associated with endometrial cancer, cancer of the uterus? A, age over 50 years. B, obesity. C, family history of uterine and or colon cancer. D, use of estrogen medications. Or E, all of the above. And we've already got some responses. If you would please take another 10 seconds or so. Again, everything's anonymous, so take your best shot and then we'll talk about that. All right, looks like we're trending on one answer again. We do have one for C and then several for E. How are they doing?
Lynn, you want to take that one?
Yeah, you know what? It's on the family history. We should have mentioned that was supposed to be included there. So that person who switched back, that's fine. And the rest of you, you're acing this. You're acing this. This is wonderful. But exactly, that there are many risk factors, and you nailed it. So great.
Yeah, there is that, as Lynn, you started to say, this what's called Lynch syndrome, where families, a very small group of families, will have colon and uterine cancer that's more common. So if you have that family history, be evaluated. On the other hand, as I said a minute ago, abnormal bleeding isn't necessarily the only cause or cancer is not the only cause of abnormal bleeding. And this is a list of some other things, so it doesn't necessarily mean you've got cancer if you're having some spotting or bleeding. But again, it needs to be evaluated to be sure. Next slide. So the diagnostic test for endometrial cancer, Pap smear might pick up some abnormal cells. Certainly we would respond to it if there were abnormal cells, but getting a sample of the tissue of the lining of the uterus where this cancer starts by either doing a biopsy in the office or by doing a DNC, obtaining more tissue in the operating room, is where we're going to make the diagnosis, by having that tissue, have the pathologist look at it, and then tell me what's going on. Now, there are some pitfalls in the diagnosis. A lot of women around the change of life, 45 to early 50s, might have some irregular bleeding, and that may be very normal, but it should be evaluated and make sure that the doctor agrees that this is just a normal change of life issue. Women that are on hormones could have some abnormal bleeding, especially, as Lynn said, if the patient is getting estrogen hormone alone without progesterone. On the other hand, believing that the pap smear, if it's normal, you don't have cancer, is not correct. And delaying diagnosis, and certainly all of us have some degree of denial, but holding off on being seen and evaluated is dangerous. So we don't want to delay diagnosis in terms of endometrial sampling. So the treatment of uterine cancer, we'll get to that right now. The treatment is surgery, and it's not only surgery for treatment, but also for diagnosis and staging, or more for staging. So removing the uterus and cervix, tubes, and ovaries is the cornerstone for treatment. Many women, that's all that we need to do, but we do need to stage and look at whether there's any spread, lymph nodes being a common area. So we would surgically biopsy those lymph nodes, have all that tissue reviewed by the pathologist under the microscope, and then base any further decisions about treatment, whether surgery is enough or not, based on what the pathologist says. In some patients, we need to add radiation therapy to the pelvis, for example, or chemotherapy to improve that patient's prognosis if she has some bad features on the pathology. So now we'll turn to ovarian cancer, which is a totally, well, it's adjacent to the uterus, a totally different cancer, about 22,000 women annually in the United States, and the risk is very low. It's about 1 in 71, or about 1.5% lifetime risk. One of the key things I would hope everybody would come to realize after this lecture is we still don't have a screening test for ovarian cancer, which is very frustrating for patients and me and Lynn and everybody else. We would like to pick it up early. Unfortunately, about 3/4 of the women we see from the first day we see them already have disease spread throughout their whole abdomen, which is stage 3, and or into their lung or liver, which is stage 4. So before we even have a chance to treat the patient, we have such advanced disease, and obviously we need to treat it. Most women are older, and if it's treated early and caught, if it's caught early, we do have a very high survival rate, but catching it while it's still confined to the ovary is very difficult. And so unfortunately, rarely do we see patients with disease confined to the ovary where we might have a 90% survival rate.
So why can't we catch this early? Well, we know we have no screening tool. So then we have to go on symptoms. So yes, there can be people walking around with early ovarian cancer and not have any symptoms. And the kind of the motto for ovarian cancer is listen because it whispers. So not to say, oh, I've been having this bloating, but if you've had it a while, that's something that should be looked at. Pelvic or abdominal pain or pressure, difficulty eating or feeling full quickly, just a change in regular eating habits, urinary symptoms of like urgency or going frequently, because if there is something in there, it can push on other organs like the bowels and the ureters and the bladder, change in bowel habits. So if they persist more than a few weeks, someone should see a gynecologist. So that's become a bit of a challenge here, especially in COVID, because people are not anxious to get their regular exams. And it is important to be able to monitor people. So when should people go to a gynecologist? Annually. But of course, if they've had these type of things and these type of symptoms are in that age group, then right away. We do have a tumor marker. So what is a tumor marker? A tumor marker is something that tells us that for the CA125, it's protein that's put out in the blood that's made from the tumor. So it is not a thing of you have, the normal range is up to 35 and somebody can have 100 or somebody can have 2,000. It doesn't tell us, it's not a linear thing of how much tumor is there, but it shows that the tumor, the ovarian cancer, and I'm using that interchangeably too, puts out that protein and gives us a warning sign that cells are still there. So it is elevated in approximately 80% of advanced cancers. So that's why we're seeing these in stage 3 or 4. Because if we did this routinely like a screening tool, it's not a screening tool because it's elevated in less than 50% of early stage ovarian cancers. And as we saw before, a screening tool is somebody who's asymptomatic and we're finding something on it, and the CA-125 would not be a good screening tool. It can be elevated, though, in a number of other benign conditions like endometriosis, fibroids, pregnancy, hepatitis, pelvic inflammatory disease, when people are having their menses, peritonitis, or recent abdominal surgery, even like appendiceal surgery or something like that. So it's not specific, but we know if we find it elevated in ovarian cancer, it gives us one more bit of the puzzle so that we can watch it. It can also be elevated in other malignancies, including breast, colon, pancreas, lung, and endometrial cancers. So if we have an elevated tumor marker of CA-125, we just can't identify that as ovarian cancer right away without other thorough exams. There is several genes actually that are associated with ovarian cancer, and they're actually discovering more and more as we do more gene testing and genomic mutations. BRCA1 and BRCA2 are ones you may have heard of. They are elevated in both ovarian cancer, can be elevated in ovarian cancers, but probably only 15 to 20% of the time, more so in breast cancers. So if you have an elevated BRCA1 or 2, you would be more at risk for developing breast and ovarian cancers. Age is a risk factor. Most ovarian cancers develop after menopause. This doesn't mean that someone who's younger cannot have ovarian cancer, but an elevated age would make it more likely. Obesity have higher death rates with ovarian cancer. Also, again, nulliparous women, women who have not had biological children, are at increased risk. And a family history of breast, ovarian, or colon cancer. Dr. Clarke-Pearson talked about Lynch syndrome, but also there's a relationship with breast and ovarian cancer in families. And then a personal history of breast cancer puts you at higher risk for ovarian cancer. But is there anything that we can do to protect against ovarian cancer? Well, interestingly enough, oral contraceptives, which suppress the ovaries, used for greater than 5 years seem to decrease the risk of ovarian cancer. Tubal ligation, removal of the tubes is also a protective effect. And women who have, if you have lots of children, not that I'm saying to go out and do that, I had 2 and that was enough. And but if women who have many children, that's a little bit of a decreased risk also. So back to screening. CA-125, we said, and I want to repeat, is not a screening tool for ovarian cancer and should not be used as such. So if you go in and say, I just want that CA-125 test, we don't want to do it. Why? Because we mentioned as before, it can identify many other different things, and many are benign diseases. 15 to 20% of ovarian cancers are hereditary. So family history of breast ovarian cancer should be evaluated for the need for genetic counseling. And actually that has grown for that right now. The present standard is that anyone with ovarian cancer will get genetic counseling and screening. Any patient diagnosed under the age of 50 should be offered genetic counseling. That's also a little bit older, but as I said, everybody who has ovarian cancer, we are offering genetic counseling.
So it's important to understand that briefly that there are really 3 types of ovarian cancer, but the one we're really talking about is what we call epithelial ovarian cancer, which starts on the cells on the outside of the ovary. The other 2 are much rarer. Epithelial cancers account for about 90% of ovarian cancers. Germ cell tumors of the ovary occur in young women, average age of about 19 or 20. They are a totally different cancer, and we're not really talking about that today. We don't have time. But they do have a different prognosis, and it's important to recognize them. But that's a different cancer than what we're talking about. And then stromal tumors, again, are a rare cancer. So we're really talking about epithelial tumors that start on the surface of the ovary. So the diagnosis, as we've been saying, we don't have a screening test, and the symptoms are vague. They're GI symptoms, as Lyn said, abdominal pressure, bloating, early satiety. On examination, if a gynecologist or physician finds an ovary that's enlarged, that's a concern. Or maybe the patient had a CT scan or an ultrasound for some other reason and the ovary's enlarged. Those would be things that we need to evaluate. So we have to be suspicious, but we don't have a diagnostic tool until we get to surgery. So if we're suspicious enough that this could be ovarian cancer, then we're going to need to do some surgery to get some tissue from that enlarged ovary and have the pathologist tell us really what's going on. So it's important to understand also that ovarian cancer spreads very quickly, it seems, to a number of sites. So once it gets past the ovary, it can float around and land throughout the abdomen. So this illustration here is showing some of the internal organs of the abdomen. A lot of things aren't there, but it can land sort of like dandelion seeds all over everybody's front yard, land there, attach and grow. So it can land on surfaces of the intestines and the bowel and the colon and on the liver. And so once it gets past the ovary, it can float around and go everywhere. And so at the time of surgery, we need to be looking for any spread by looking at all these different areas. So it has to be very comprehensive in doing the surgery. Next slide. So the goals of the surgery: one, I need to get a biopsy and make a diagnosis that this is in fact cancer. And then we're going to determine the extent of spread. So I need to examine the entire inside of the abdomen, including lymph nodes. And then the third goal, because most times the cancer is spread, is what we call debulking, removing the bulk of the cancer, or preferably removing everything I can see and feel. Some of that has to do with the surgeon's skills. Can they do certain things like bowel surgery? Sometimes it has to do with where the cancer spread, and you and I have no control over that. But trying to remove as much cancer surgically is important. And then fairly quickly getting on to chemotherapy. And we won't go through the details of that, but chemotherapy can be highly effective against even advanced stage patients. As we said, patients with stage 3 and 4 disease account for about 75% of our patients. With good treatment, somewhere around 30 to 50% will be surviving at 5 years, although many of them will still have cancer that we're treating off and on. So this is what we're dealing with ovarian cancer. Okay, and now we're going to spend the rest of the talk on cervix cancer. This is cancer arising in the lower part of the uterus, which is called the cervix. Some people call it the mouth of the womb. And this is where we do pap smears. And so we're going to talk about screening for this, because we can screen and we can even prevent cervix cancer if we do the right things with HPV vaccination. Next slide. So if you think about women in the world, cervix cancer accounts for a third of, is the third leading cause of cancer death of women in the world, predominantly not because they can't get treatment, although many can't, but most of the time we don't have screening. Women in Africa and Asia are not getting pap smears, unfortunately. And so this is a big deal in the world. In the United States, it should be a different story. If we can catch cervix cancer early, 92% of patients can be cured with proper surgery or radiation treatments. Whereas if it's spread locally out into the pelvis, only about half the women will survive. And if it's spread beyond the pelvis at initial diagnosis, the survival is about 15%. So early detection is important. Next slide. Very important. And as I've said several times now, we could nearly eliminate cervix cancer if we did proper pap smear screening, and we'll talk about how that should be done, and if women were vaccinated going forward. Next slide.
So something you should know about me, this is my hero, Dr. George Papadopoulos, who saved actually millions and millions of lives of women around the world by providing us with a tool, and you can see his name, the pap smear for early detection of cancer of the cervix. Before that, cervical cancer just advanced. There was no way, but now we have a screening tool to identify that. So Dr. Papanicolaou, what did he do? When we do the pap smear, the scraping of cells of the area of the cervix, and then look at them underneath a microscope and see if there are any worrisome cells. That's what he did, and showed us that with microscopic examination, we can find cervical cancer earlier, or even abnormalities that aren't cancer but are just abnormalities. And you can just keep rolling them. And the cellular abnormalities, sometimes it's a little continuum, but it's a big jump from an abnormal pap smear to cancer, but it gives us an alert that we can watch that. Cervical cancer death rate declined by 74% between 1955 and 1992, mostly because of the effectiveness of pap smear screening. So that's just amazing. And about 55 million pap tests are performed each year in the United States. Of these, approximately 3.5 million are abnormal, not cancer, but are abnormal. But between 60 and 80% of American women with newly diagnosed advanced invasive cervical cancer have not had a pap smear in the past 5 years. So that truly is a risk factor. I'm just going to go to the American College of Obstetrics and Gynecology, and just that first line of recommendations so you can get an idea. These are recommendations for people who have normal paps. So under 21, we don't recommend that unless unless somebody sees an abnormality. And then from ages up, the screening is every 3 years if we have normal exams. Next slide, please.
All right, and we do have another poll. Thanks so much for all the participation on these so far. Which true statement or statements, which are true statements about pap smears? One or more of these are true. A screening test for ovarian cancer. B, abnormal pap smears are caused by a virus. C, should be performed only in women who are having abnormal bleeding or pain. D, abnormal pap smears are most often caused by use of birth control pills. Or E, should be performed beginning when a woman is over 15 years old. So you pick the statement or statements that are true. And we'll take about 5 more seconds here. All right, so we've got a nice variety of answers. How did they do?
Oh, you want to take it, Lynn?
No, you're going to take it.
All right, I'll take it. So we've tried to emphasize that we don't have a screening test for ovarian cancer. So to look at what's going on in that ovary, taking cells from the outside of the cervix does not show us any abnormality. So it's not a screening test. It is caused by a virus, and we're going to talk about that a lot more. That virus is called human papillomavirus. There are several of them, but they all fit into the same virus family, and we can vaccinate for that virus or those viruses. So that is the correct answer. Performed in women only having abnormal bleeding, no, that we're really talking about uterine cancer, and that's not a screening test for it. It's not caused at all by birth control pills. Birth control pills don't cause cancers that we're aware of. And beginning at age 15, no, that's a little early. Age 21 is when we would recommend starting to do pap smears. So the correct answer is that pap smear is caused by an abnormal by a virus.
So I'm going to go through some other risk factors for cervical cancer. Women that are sexually, you can just roll it, sexually active before age 16. Women with multiple sexual partners, because since it is caused by a virus, you're spreading a virus, just like if you were sneezing in 10 people's faces. Smoking, interestingly enough, does affect cervical cancer and is a risk factor. Obesity, African American status, low socioeconomic status, and that's mostly associated with not being able to get medical care and being screened when they don't have symptoms. certain strains of human papillomavirus. Just like we have different strains of COVID, and now they're new, they call them variants. There also are different strains of human papillomavirus. So it's not just one thing, like antibiotics are not just one thing. HIV in patients, and a history of DES exposure, which I won't get into because that's a little complex. Human papillomavirus. What is HPV? And you probably heard the initials because that's a lot easier. And who should get an HPV vaccine? This is my favorite part of the talk because I think this is the teachable moment. HPV is the most commonly sexually transmitted infection. HPV is a different virus than HIV and HSV, which is herpes. But there were about 43 million HPV infections in 2018, many among people in their late teens and early 20s. So 43 million in 2018. And later on I'll say, but I'll tell you now, about 79 million people are affected with HPV. That's not, again, that is usually a latent infection that isn't bothering, but some of these HPV types are associated with cervical cancers and other cancers. There are many different types. So some types can cause health problems, including genital warts, and others cancers. However, there are vaccines that can stop these health problems from happening. How is HPV spread? Like we said, it's a sexually transmitted disease by having vaginal, anal, or oral sex with someone who has the virus. It is most commonly spread during vaginal or anal sex. HPV can be passed even when an infected person has no signs and symptoms. Transmission, anyone who's sexually active can get HPV, even if you've had sex with only one person. You also can develop symptoms years after. You don't just get HPV 2 days later. It can develop over years after you've had sex with someone who's infected. That makes it hard to know when you first became infected. So if you've had sex with someone in 1918 and somebody else in 1919 and somebody else in 1920. Oh, I don't know why I'm saying 19, but anyway, yeah, consecutive years, you can't identify where that came from. But almost all females and males will be infected with at least one type of HPV at some point in their lives. Estimated 79 million Americans currently are infected. As I said, 14 million new infections a year in the US. HPV infections are the most common in people in their teens and early 20s. And again, so important, these are not all HPV infections that cause cancer, but some of them are. So this is really important. This is where people go home and yell at their kids, but nearly 50% of high school students have already engaged in sexual intercourse. 1/3 of 9th graders and 2/3 of 12th graders have engaged in sexual intercourse. And interestingly, 24% of high school seniors have had sexual intercourse with 4 or more partners. So that puts them at high risk.
So I'm going to throw this in. It's not on a slide, but we've been talking about cervix cancer being caused by HPV, but Lyn sort of started to mention it. So HPV can also cause oral pharyngeal cancer in men and women, anal cancer, cancer of the penis in men, and vaginal and vulvar cancer. So it's not just cervix cancer that we're trying to prevent by vaccinating, and we'll talk about that some more. So HPV vaccination can prevent cancer and can prevent warts. About 36,000 cases of cancer in men and women every year could be prevented with this vaccination, and 32,000 cases can be prevented as well. So I think it's really important for us to go ahead and talk a little bit more about HPV vaccination.
So that's a huge thing, that we have something that prevents cancer. Believe me, every cancer patient that comes in wants to know how it could have been prevented. So cervical cancer is the most common. There are 500,000 new cases and 275,000 attributed to deaths worldwide, and that number has gone up instead of down, actually. 25.9% of cervical cancers occur in women who are between the ages of 35 and 44, again explaining the lag time for it to develop. 14% between 20 and 34, and 23.9% over 45 and 54. So again, this is showing that HPV can be a problem over a lifespan, but we can prevent some.
So the vaccine, I think we've had now for nearly, well, 15 years or more. It's highly effective. It's been well shown that we can reduce HPV infections by 95% or more with this vaccine. It's widely available. There's no shortage. There's no difficulty in distributing it like we're having with COVID right now. And it doesn't seem to be, if women have had one prior infection with HPV, they can still get the vaccine because the vaccine covers 9 different HPV types. So if you've had one HPV type, why not go ahead and be vaccinated against the other 8 before you get it? There's no evidence that giving the vaccine will reverse an infection. So if a woman's already infected, the vaccine isn't intended for that. It's intended to prevent the infection from happening.
Okay, we're going to roll some slides fast because we're nearing the end. So for most women who have an HPV infection, it can clear on its own, but some it can develop into cancer. Dr. Clarke-Pearson alluded to 9 types of HPV that we've identified that cause the most diseases. It can be effective against genital warts. In a study of female college students, 60% were infected with HPV during their first 4 years of college. And many women with HPV probably became infected in their teens and 20s.
I think it's important to point out that we're looking at large numbers of women that are infected, but most won't get cancer. So it's important that we screen for cancer. Most won't go on to develop cancer, but some will. That's the risk factor. So screening for cervix cancer was revised. It should be 21, starting at that age group. And then screening every 3 years, and then screening women up to age 65 is what Medicare will compensate for. So those are the screening routines, beginning at age 21 every 3 years. When to get vaccinated. So I think the recommendations from the FDA and the CDC are to try to vaccinate boys and girls, not just girls, at ages about 11 to 12 years of age before they have a chance to be exposed to HPV. If they haven't been vaccinated at between 11 and 12, we can still vaccinate. And in fact, the FDA supports vaccination up to age 45, 46 in women and men and boys. So I think those are the routine for vaccination. They're pretty straightforward, and we just need to be doing that.
And notably too, that in high-risk areas, children can, and now we're talking hardly about women, but children who are vaccinated the girls can be vaccinated as early as 9 years old. We're vaccinating both because it's both men and boys and girls because it's a virus. So it can be spread to both of them. And it's important to get that in before a child is sexually active. Once someone has the HPV infection, we cannot treat that with a vaccination. A vaccination is just preventative. Again, just like COVID is not treated with a vaccination. The usual adverse effects are we're running through, I guess, but that's fine. They're the usual things like pain, swelling, redness. That's what erythema is. Some people have fever, nausea, or a headache. But when you're vaccinating children, they always have a headache. We can move. Next slide, please.
So how do we diagnose cervix cancer? Oftentimes we hope we can pick it up because we have an abnormal pap smear, and then we go on to evaluate that patient and obtain biopsies of the cervix. Let's just keep rolling also. But the pap smear is not a diagnostic tool, so it could miss a cancer. So if a patient's having bleeding or pain, needs to be evaluated. But we do, as I said a minute ago, take a biopsy, have the pathologist tell us under the microscope that this is cancer. The next slide. And the symptoms, sometimes there are some symptoms, unusual vaginal discharge, some bleeding after intercourse, because that cancer on the cervix is being rubbed or irritated and can spot and bleed, and it can cause pain. So there are some symptoms, but those symptoms oftentimes aren't really early symptoms. So we'd like to pick it up with a pap smear before there's any symptoms at all. Next slide. And then treatment of cervix cancer. Early treatment of cervix cancer, we can just roll through this, could be either surgery or radiation therapy. A radical hysterectomy, removing the cervix and uterus and the tissue beside the cervix. The ovaries can be preserved, is one operation that's very effective. Radiation therapy, on the other hand, combined with chemotherapy, can be used and is used for patients that have more advanced disease. And it can be highly effective as well.
All right, and here's our last poll question. Which of the following are true about HPV, about the HPV vaccine? So which of the following are true? A, could eliminate nearly 90% of cervical cancers. B, a woman should get the vaccine even if they have had an abnormal pap smear. C, approved by the FDA for both girls, women, and boys, men. D, could eliminate up to 9 HPV types. Or E, all of the above. And we'll take about 5 more seconds if you haven't already answered. All right, seems like we're landing on E with some folks also thinking D. How did they do?
Well, since they're all correct, so the D's get credit too. They get partial credit, but it is all of the above, that it can eliminate cervical cancers. It can prevent cervical cancers. We did not address this, so B is a little unfair, but if you have an abnormal pap smear, yes, you still get a vaccine. It's only if you've, well, I guess that's hard. Yeah. But, and also if it's approved, it is approved by FDA for both women and boys, or girls and boys. Okay. Teachable moments are to evaluate family history. And when you're taking, when you're asking people to do things, a positive spin for treatments, to go in to see the gynecologist and get a pap smear reduces your risk for cervical cancer. To get a vaccination, yeah, it's not fun to get a vaccination, but it reduces the risk almost 90% for cervical cancers. And to teach the patient and the family about the disease and why we're giving these vaccinations and making these recommendations. So how about you? We also have to care for ourselves, and this is an important time to do that. So there is on the Women's Cancer Network an assessment tool that is 101 brief questions assessing your personal risk for a variety of cancers. And it's interesting to do that so you understand the risk factors. And as Herbie says, we still have a long way to go on behalf of our gynecologic oncology patients. We need to develop a screening tool for ovarian cancers and endometrial cancers, but with knowledge and understanding, we can help them in their journey. And we always celebrate a win. This is the soccer team, so thanks for being part of our team and learning about these important issues to us and to our patients. Thank you.
Yeah, thanks for being part of the meeting today. I hope you've learned something.
Thank you both so much. While we're waiting to see if we have some questions roll in, I forgot to ask something at the beginning. So let me ask each of you, what was your career trajectory in terms of getting to where you are now in the oncology field? What sort of sparked your interest, and what were the decisions that you made to get to this point? Lynn, would you like to kick that off?
Yeah, I was interested in cancer early on, and then I was fortunate enough to work right out of school to work with GYN oncology patients, and I just love this patient population. I worked in it a very long time, but it's a population that I love so much that I just enjoy every day at work, and that's honestly true. But they still have to give me a raise, but that's true.
There you go. And Dr. Clarke-Pearson, what about you?
Well, first of all, we're working on the raise for Lynn, and then I think in medical school, I was attracted to obstetrics and gynecology and got trained in that first. But in the course of that, realized that our subspecialty of gynecologic oncology allowed me to take care of the entire care of that patient, not just surgery, not just chemotherapy, not just radiation therapy, but the entire course of her care and then follow-up too. So that longitudinal care means a lot to me. I hope it means a lot to our patients to not have to go from one doctor to the next, but can be taken care of by a subspecialist that really is an expert in that particular area of cancer care.
Great. Thank you both. And while we're waiting, we still have just a couple of minutes here. Any special advice that either of you would like to give to any students, nursing students, allied healthcare students who are considering a career specifically that is oncology related?
I think it's a very, very rewarding career. It's one that's not going to go away, that we need people all the time. And it's wonderful because besides the treatment and the inspiration from these really wonderful patients, we also get to be able to help to prevent a cancer over all these years. That's exciting too, and really impart the knowledge and the teachable moments. And that's a lot of education, and that's quite rewarding. I would highly recommend that.
Thank you. Good to hear. Dr. Clarke-Pearson?
Well, I mean, I think as in lots of medicine, there are advances continually going on, which keeps me stimulated to not just be in a rut, but we're constantly making progress. And obviously, we'd like to cure cancer. We have been making progress. I'm convinced of that. But to be part of something that's as well. I think as we understand the genetics, the molecular genetics of cancer, we are going into a whole new realm of cancer treatment that can be very specific for an individual person's cancer. So to me, it's very exciting.
All right. Thank you both. Let me see. It doesn't look like we've had any other questions. I'm going to move to a couple of other slides and then we'll revisit and check and see if we had any last minute questions. We do want to say thank yous as always. We are incredibly thankful for the generous support of the North Carolinians across the state through their tax dollars supporting the University Cancer Research Fund and the UNC Lineberger Comprehensive Cancer Center. We want to thank Mary King, Veneranda Obore, and John Powell for all that they do for each and every one of these presentations.